Good morning, everyone. Today, before moving on to the prediction of the occlusal morphology by automating method, we should discuss about the occlusal considerations when we are making the conventional crown and bridge, as known as the fixed prosthodontics. For those who are not yet conversant with this principle of occlusion, this short time with the practical techniques for recording and reproducing occlusal relationship is intended as an introduction to the whole subject. It will be sufficient for making crowns and bridges for patients with no functional disturbances or pathological changes in the temporomandibular joint or the orofacial musculatures and no major occlusal abnormalities. In other words, most patients for more difficult occlusal problems, you should study more. For many years, there has been considerable interest in normal and abnormal occlusions and the effect of the abnormality. There is a rapidly expanding literature, both research based and empirical. An unfortunate side effect of this enthusiasm is that the whole subject seems to be confused in some dentists' minds with the use of complex articulators, recording devices, and expensive full mouth rehabilitations. The all or nothing law seems to apply, with some dentists apparently blaming most of the human race's ills and all of its dental ones on the odd aberrant cusp, while some others remains unconvinced, throwing the baby out with the bathwater, paying little or no attention to occlusal relationships other than when a filling or crown is high in the bite. An understanding of a few simple principles of occlusion related to natural teeth, and in particular, how to examine occlusions encourages a middle course between these extremes and will be of great value in preventing some of the failures that occur with restorations that replace occlusal surfaces. Elaborate equipment is unnecessary for the application of these principles to the restoration of small groups of teeth. Equipment should be seen simply as a means to an end. In fact, the principle determining the design of articulators and recording devices is fairly simple, but their conversion into three-dimensional reality leads to the complexity of the equipment. Moving on to the functional approach to occlusion. The most useful way for a restorative dentist to look at occlusion is from the functional point of view. The morphological details of the occlusion are less important. The fact that an occlusion is an angle class 1, 2, or 3 is less important than the way the teeth move across each other in various movements of the mandible. For example, in lateral excursions in some patients, the canines are the only teeth in occlusion, and in others, several of teeth are in occlusion. The restorative dentist should also recognize that crown bridges of any restorations involving the occlusal surface will often affect the way the occlusion functions. This effect should be deliberately planned rather than be allowed to influence the occlusal movement by the accident. The functional compared to with the orthodontic approach should be discussed. Orthodontic treatment is aimed primarily at improving the patient's appearance and producing a stable posterior occlusion in a single static position. Some forms of orthodontic treatment go further and establish deliberate patterns of contact between the teeth in various movements of the mandible. Most orthodontic treatment is carried out on young people who have not yet developed the rigid pattern of involuntary neuromuscular control of the mandibular movement. They are, therefore, capable of adaptation to fairly drastic changes in their occlusal relationships in a way that some older patients find difficult. From the functional point of view, there should be no difference in the objective of the orthodontist and restorative dentist, only different means of achieving them. Let's discuss now fixed compared with the removable prosthetic approaches. The main purpose of designing the occlusion for complete denture is to produce stability of the denture basis. This is an entirely different concept from the restoration of natural teeth with intact roots and periodontal membranes. Occlusal considerations for partial dentures fail somewhere between these two positions. In complete denture constructions, considerations of where the occlusal surfaces of the artificial teeth should be in relation to the ridge, the presence of balancing context of the non-working side, and the angulation of cusps or absence of cusps together are important. None of this applies in the same way to the construction of fixed restorations. The method of recording and reproducing mandibular movement are similar, whether fixed or removable appliances are being made. However, the principles governing the design of the occlusal relationships, although similar in some aspects, are different in others. Okay, let's look into some mandibular movements and definition of terms. The movements that mandible can make, the names of the important position with this range of movement are to be discussed. Terminal hinge axis and the retreated arc of movement, or occlusal. This is an axis which passes through both condyles and about which the mandible rotates in most retreated or comfortable position of the condyles, the retreated arc of closure. This is a clinically reproducible movement, and recording it is often useful in making crowns and bridges and essential in making complete dentures. The terminal hinge axis can be measured in individual patients, but it is sufficient for most applicants to use an average terminal hinge axis such as that recorded by an elbow as discussed in later. Intercuspal position, as known as ICP, the abbreviation. This is the position of maximum contact and the maximum intercuspation between the teeth. It is therefore the most cranial position that the mandible can reach. The term centric occlusion has been used to describe this position, but this is confused with centric relation and may also imply centricity of condyles in their fossa, centricity of the midline of the mandible with the midline of the face, or centricity of the cusps within the fossa of the opposing teeth, none of which may be the case. The term centric occlusion is therefore better not used. The next is the retreated contact position, RCP. This is the most retreated position of the mandible with the teeth together. It is clinically reproducible position in the normal conscious patients. Patients with conditioned patterns of muscle activity may not be able to manipulate the jaw into it, even with assistance by the dentist. And less than 10% of the dentate population of the RCP coincide with the ICP. In the remainder of the RCP is up to 2 mm or more posterior to the ICP. The term centric relation has been used to describe this position, but it has the same disadvantage as the term centric occlusion and will not be used. Centric occlusion and centric relation are terms sometimes used in complete dentures constructions where they mean different things to ICP and RCP. The next is the mandibular movement. Those patients who have discrepancy between the RCP and ICP usually close straight into the ICP from the posture or rest position when the movement is made subconsciously. Patients sitting in dental chair making voluntary conscious movement when asked to do so by the dentist often make bizarre movements rather than closing into the ICP directly. These aberrant movements contacts are the result of patients trying too hard to help and not understanding what is required. Students have been heard to ask non-dental or medical patients to bite on their posterior teeth. However, contacts does occur in the range between the ICP and RCP during empty swallowing, particularly nocturnal swallowing, during the mastication of tough bolus, and during parafunctional activity. Thus, the mandible can slide from the ICP in four main directions with the teeth in contact or in an infinite number of directions at angles between these main pathways. The four excursions are retrusive, protrusive, left lateral, and right lateral. Let's look at the bodal movements of the mandible in this picture. First, in the picture A, the maximum possible movement of the tip of the lower central incisor is depicted. The teeth are in occlusion from RCP to the fully retreated position at P. In opening from RCP to X, the mandible rotates in a pure arc of the circle around the axis. That is the terminal hinge axis, as known as the THA, which passes through the condyle. X is the maximum opening that can be made without the condyle moving forwards, and the R is the maximum opening with the condyle fully protruded. In the picture B, the view from the above showing RCP and ICP. The movements are not pure arc of circle because when the mandible moves to the side, the condyle on the working side shifts laterally. It is called as a Bennett movement, and the condyle on the non-working side moves forward and medially. It's a Bennett angle. In the picture C, the bodal movements viewed from the in front is depicted. The movement from the ICP to the cusp contact, C, is guided either by the canine or the anterior tooth or a group of posterior teeth. From C to the maximum lateral position, L, the guidance is irregular and usually controlled by the anterior teeth or teeth on the non-working side. This is a non-functional range not usually involved in the parafunctional activity and is therefore of little importance. In picture D, changes in the lateral guidance will either expand the original bodal movement, Y, or encroach upon it, Z. Both change constitutes occlusal interferences. The change Y would result, for example, from the fracture or extraction of canine tooth that previously governed lateral guidance. The change Z might result from overbuilding the cusp of posterior crown in a group function occlusion or from the development of non-working side contacts. In picture E, the occlusal interference, an irregularity developing in smooth movement from ICP to RCP, may also result from the crowns. In picture F, an expansion of bodal movement is often an objective of occlusal adjustment in the range from ICP to RCP. For example, if the original movement was from ICP to RCP I, with the large vertical and horizontal components to the movement, an adjustment could be carried out to produce a long centric, so that the movement was flat from ICP to RCP2. This would not change the horizontal components of the movement, but would reduce the vertical components to zero. The alternative of making ICP and RCP coincident, RCP3, usually involves multiple crowns or either restorations as well as occlusal adjustment. This is because either the bodal movement space needs to be encroached upon, the dashed line, or a substantial amount of teeth must be removed. When this is done, the process is known as the reorganizing the occlusion. If ICP is left undisturbed, the occlusal plane is known as the conformative. Regarding retrusive movements, movements between the ICP and RCP are usually guided by a limited number of opposing pairs of cusp or posterior teeth. The figure illustrates the occlusal contact point produced in RCP and other excursions in a typical natural dentition. The angle of the slide between RCP and ICP, its length, and the individual pairs of teeth that produce it are important and should be examined. Of even greater importance is any unevenness of the movement producing bulges or lumps in the path of movement. These disturbances to the smooth movement of the mandible are one form of occlusal interference. Next is the protrusive excursion. In forward movement of the mandible with the teeth together, it is usually incisor teeth that guide the movement. This will not be the case in anterior open bites or in class 3 incisor relationships. The angle and length of movements will be determined by the incisor relationship so that, for example, in a class 2 division 2 incisor relationship with an increased overbite and reduced overjet, the movement of the mandible has to be almost vertically downwards before it can move forwards. Anterior guidance is important when making anterior crowns or bridges. Sometimes when the teeth are a normal shape, it is helpful to reproduce the patient's existing guidance as accurately as possible. On other occasions, for example, with one tooth, it is unnecessary or undesirable to do so, and in fact, the purpose of the treatment may be partly to alter the incisor guidance. The final is the left or right lateral excursions. In lateral excursions, the side that the mandible is moving to is known as the working side, and the opposite side is the non-working side. The term balancing side has been used to refer the non-working side, but since it implies a balanced occlusion, balancing or stabilizing a complete denture base, it should not be used in reference to natural teeth. The contacts on the working side are either between the canine teeth only in canine-guided occlusions or between groups of teeth on working side in group functions. Occasionally, individual pairs of posterior teeth will guide the occlusion in lateral excursion, but this is not regarded as ideal. The canine-guided occlusion is considered to be protective of posterior teeth, which discludes in lateral guidance. Contact on non-working side in lateral excursion should not normally occur. It does sometimes occur after extractions and oval eruption and occasionally following orthodontic treatment, particularly when this treatment has been carried out with removable appliances that allow the posterior teeth to tilt. Contact may also occur in cases of posterior crossbite, where the lower teeth are placed buccally to the upper teeth. Now let's discuss about the occlusal interferences and occlusal harmony. First is occlusal interferences. An occlusal interference may be defined either as a contact between teeth in one of the excursions of the mandible so that the free sliding movement of mandible is interrupted or uneven, or as the guidance of the mandible being carried on teeth that are unsuitable for the purpose. In many cases, occlusal interferences develop sometime after the eruption of the permanent dentition and are the result of the dental treatment. The figure illustrates an alteration to the movement between ICP and RCP resulting from the oval eruption of a tooth. This constitutes an occlusal interference in this excursion. These interferences are often difficult to detect because the sensory mechanism within the periodontal membrane of the teeth involved detects the interferences and triggers a conditioned pattern of mandibular movement to avoid it. This accounts for the difficulty many patients have in permitting their mandible to be maneuvered into RCP and also the difficulty they have in voluntarily making lateral excursions with teeth together. An interference in the intercuspal position resulting from a high restoration involving the occlusal surface will be readily detected by the patient, who will usually comment on occlusal change as soon as the restoration is inserted. These instant entirely artificial interferences are obviously easier to deal with than occlusal interferences in the various excursions of mandible, which may be artificial but can also develop slowly and naturally following extractions, tooth movements, occlusal wear, and oval eruption. Interferences should be suspected if the patient has difficulty in making voluntary protrusive and lateral excursions with the teeth in contact, or there is a difficulty in maneuvering the mandible into reproducible RCP. Interferences can also be detected by the dentist resting a finger gently under the patient's chin while the various excursions are performed. Irregular movements, which the finger will fail, indicate interference that will need fuller investigation. Occlusal harmony. Occlusal harmony is the absence of occlusal interferences. A harmonious occlusion allows smooth, comprehensive movements of the mandible in all excursions with teeth together without strain or discomfort. The movements will not cause harmful effect to the teeth. For example, tooth mobility, fractured cusp, or excessive wear. A harmonious functioning occlusion will usually also involve fairly shallow angular movement in the guidance from ICP in all four directions. Patients who do not have free sliding movements may not have symptoms. They have adapted to their occlusal interferences and there is no need for treatment. However, if the occlusion is altered to produce a new and different occlusal interferences, for example by unsatisfactory crown and bridge, the patient's neuromuscular mechanism may well experience difficulty in adapting to these, resulting in damage to the restorations or teeth, or dysfunctional disorder leading to the temporomandibular joint pain, muscle pain, or spasm, or postural and functional problems. These disorders arising from occlusal disharmony are described later and are more fully described in other specialist textbooks. Now let's discuss about the premature contact. The term premature contact should not be used in relation to the natural dentition, only with the complete dentures. With complete dentures, there is no natural ICP, and ICP and RCP are made to coincide. In other words, the artificial teeth interdigitate on a retreated path of closure. The patient learns subconsciously to close on this reproducible path of closure and closes into intercuspation. When, as a result of inaccurate occlusal records, the ICP and RCP of the complete dentures do not coincide, the patient may close on the retreated path of closure and then may slide into maximum intercuspation, or alternatively, the dentures may move. This is known as a premature contact and is clearly unsatisfactory. The artificial teeth do not have a periodontal proprioceptive system, and so the position of artificial ICP cannot readily be detected. With the natural dentition of ICP is well recognized by the neuromuscular mechanism, and the mandible closes directly into the ICP in great majority of involuntary closing movements. It may not do so in the artificial environment of the dental chair when the mandible is brought under voluntary rather than the involuntary control. In these circumstances, even if the first contact appears to be premature contact, this should not be assumed to be the normal pattern of closure, but only the result of the patient concentrating on a movement that is usually entirely automatic. For this reason, the term occlusal interference, as defined and described above, should be used for the dentate patient and not premature contact. The next is occlusal stability, not the same as the harmony. The stable occlusion is one in which over-eruption, tilting, and drifting of teeth cannot occur and therefore cause new occlusal interferences. For an occlusion to be stable, there must also be sufficient posterior context to prevent the general collapse of the posterior occlusion, resulting in a loss of occlusal vertical dimension. The figure shows a disordered but stable occlusion, a disordered and unstable occlusion, and an occlusion that has lost posterior support to the point where collapse and the loss of occlusal vertical dimension has occurred. In a stable occlusion, all the teeth should have occlusal contact with either another teeth or a prosthesis, such as occlusal stops. Major drifting should be prevented by the presence of contact points, either with other teeth or a prosthesis, or by adequate cuspal locking with the opposing teeth in the intercuspal position. Not all partially edentulous occlusions are unstable. For example, if all the molar teeth are extracted, the remaining teeth may be still in the stable occlusion. Therefore, extracted teeth are not always replaced. In any case, a degree of instability is sometimes acceptable. The next topic is also important, and it is named as occlusal vertical dimension. Sometimes it is written as occlusal vertical dimension, OVD. The occlusal vertical dimension is the relationship between the mandible and the maxilla with the teeth in ICP, that is, the face height with the teeth in occlusion. It is usual to measure the difference between the rest position and ICP, the freeway space, to give an indication as to whether the OVD, occlusal vertical dimension, is within the normal range. However, rest position is difficult to measure with any precision, particularly in dentate patients, and the normal freeway space may be 2 to 5 millimeters or more. Occlusal vertical dimension is therefore judged as much as it is measured by the patient's general facial appearance with the teeth together and apart. In most cases, requiring crown and bridges, the occlusal vertical dimension is satisfactory. In some, it has been reduced by the extraction of teeth, by tilting, drifting, and collapse of the posterior occlusion, or by rapid wear of the teeth. In this, it is necessary to restore the original occlusal level of both aesthetic and technical regions. In other cases, gradual wear of the dentition has resulted in very short teeth, so that making aesthetic and retentive crowns is a problem. Yet, there is no loss of facial height because the tooth wear has been compensated by over-eruption. In these cases, a decision must be made between accepting that the natural or artificial crown will have a short appearance. Number 2, creating an interocclusal space between the teeth to be crowned without altering the other occlusal relationships. Number 3, artificially increasing the occlusal vertical dimension by restoring or replacing all the occlusal surfaces in one or both jaws. Artificial lengthening the clinical crown by gingival surgery, or sometimes alveolar surgery crown lengthening. A combination of these approaches. As the final one, when a change in occlusal vertical dimension is planned, whether or not it is to restore lost facial height, it is usual to assess the tolerance of the patient's neuromuscular mechanism to the change. A removable acrylic plate covering all the occlusal surfaces of one arch and increasing the occlusal vertical dimension by at least the same amount as it is proposed for the final restorations may be fitted. Alternatively, the teeth may be temporarily built up with composite amalgam or temporary crowns. The temporary adjustment to the OVD should be left for several weeks to ensure that problems do not arise with the neuromuscular mechanism or the teeth before the change is made permanent. The final topic is the creating interocclusal space for teeth to be crowned. In certain circumstances, particularly extreme wear of anterior teeth, it is helpful to carry out minor orthodontic treatment to enable crown preparations to be carried out without further preparation of the wound surfaces. Often, the wear has been sufficiently slow that over-eruption has kept pace with it, carrying it the gingival margin along with the over-eruption. Conventional orthodontic treatment can be used, but a simple, reliable, rapid technique is to use either a removable or fixed appliance commonly known as a Dahl appliance. Dahl originally described a removable anterior biplane made of cast cobalt chrome, but modern adhesive technology has enabled a simpler fixed appliance to be made that is well tolerated by most patients and that usually achieved the required result in about 3 months. Alternatively, the same effect can be produced by building up the teeth with composite or by preparing the teeth and fitting acrylic provisional crowns made in the laboratory, which are high in the occlusion. Okay, that's all for today. And the next week we will discuss about the temporomandibular joint and how to examine and analyze the occlusion of the patient. Thank you for watching and have a good week.